Welcome everybody to Surgeon's Log 2021, our 11th episode of season 2. And it is indeed a great pleasure to be with you yet again. We have gone to this once per month format, so we see each other less often now, but hopefully we are still generating exciting episodes for you to follow. Welcome to everybody to the webinar from the North American sector. I think the European friends are maybe with us today as well a little bit. You know what's interesting? We always show that little movie at the beginning of the webinar to entice people to join the NASBS and whatnot. And it always says, can you name this piece of music? And no one's ever named that piece of music. I bet you anybody who comes close to doing this, Dr. Nanda would be the one that actually might nail this piece of music. We'll see. Anyway, so Mike, can you go to the slides and I can introduce our guests today. This webinar is nothing without the presenters, because the presenting surgeons always bring the cases with all the teaching value to us. We are indebted to Brad Zacharia, right? Or is it?
Yeah, Zacharia, yeah, that's it.
Zacharia, who is actually my neighbor down the street in Hershey, associate professor of neurosurgery in Penn State University, and of course, director of skull-based surgery at Penn State University in Hershey. He is the one bringing the case today. For us. Our honored discussant is someone who yet again doesn't need any introductions. If you don't know Professor Nanda, you really crawl from under a rock here. Yet another one of the past presidents of the NASBS that is serving as our discussant today. He is, of course, professor and chair of Department of Neurosurgery at Rutgers University, also a neighbor of mine on the other side of Route 78. Just one way going that way and the other way going the other way. So he will be giving us his wisdom as to the case and how it was handled, what his thoughts are at the end of the webinar. We always begin the webinar with a trainee on the hot seat who does not know anything about the case, who would go through the case with a moderator to verbalize the decision-making process for the audience. Today we have Jake Young, who is I believe, PGY5 resident at UCSF, correct? And even though the quizzer is one of his teachers, he does not know the case, and he will be helping the audience think through the decision-making processes. So without further ado, I'm handing over the moderation of the webinar today to Dr. Michael Wong, my course director. And Dr. Nanda is the one who supplied the name of the webinar, Why the Owl of Minerva Flies at Dusk. I believe it has some Roman connotations and whatnot, but he'll explain to you afterwards. So Michael, please take it away with Jake.
All right, great. Thank you very much, Dr. G. So Jake, this is a case of a 41-year-old woman who comes to you with complaints of headaches for the past several years. They've been getting progressively worse and now they're persistent. She describes the headaches as pressure-like and they're associated with some dizziness. In addition to the headaches, about 18 months prior to seeing you, she started having intermittent blurry vision in the right eye. She has actually been seen by neuro-ophthalmology for this complaint, and they found that she has a right APD, and also a right-sided inferior arcuate defect. There was thinning of the right optic nerve, and also some mild disc edema on the right. Other complaints include facial pain that is dull, but also intermittently sharp and stabbing in the right V2 distribution. And she's also complaining of right ear fullness and tinnitus. She actually has had Meningotomy tubes placed about a year prior to the presentation, but still continue to have symptoms. And she was actually seen by ENT and being considered for a Eustachian tube balloon for her persistent symptoms. On your exam, she's oriented. She does have right proptosis, a right afferent pupillary defect, and right ptosis. Her extraocular movements are actually intact. The face is symmetric, no facial sensation asymmetry, but she does have significantly decreased hearing on the right side. Other parts of her neurological exam are stable or normal. Any questions regarding the history?
Well, that was very detailed, but I think just a couple more questions about the headaches. It sounds like we don't have any temporal association with them particularly worse when she wakes up in the morning. Any associated nausea, vomiting?
Not that we're aware of.
It'd be unusual for hydrocephalus to be the cause of the blurry vision when it's unilateral and very focal, but just to be sure, it's also reassuring there's no signs of myelopathy, but is she having balance problems or any recent falls?
No.
Okay. Yeah, I think that's it.
Okay, great. We'll go on to imaging. So she comes to you with a CT scan. I'll scroll through it and then.
Yeah, we're scrolling through the axial CT here. Immediately, my eyes are drawn to the hyperostosis that's evident, the right temple bone along the sort of sphenoid wing towards the petrous portion of the temple bone, as well as even the lateral orbital wall. Could you scroll through one more time?
Here's some axial and sagittal recons.
Yeah, so looking at the axial coronal and sagittal bone window here with CT, once again, my eyes drawn towards the hyperostosis. It's evident along basically the entire right lateral orbital wall towards the sort of floor of the middle fossa, around the, yeah, exactly. Getting down towards the clinoid and looking at the sagittal, you don't appreciate much hyperostosis anywhere around the frontal bone. And I don't actually see any lytic lesions or anything concerning for other abnormalities other than what we've already described. So I'd like to proceed with an MRI with and without contrast. And so here we're looking at axial post-contrast T1 weighted MRI scan. And then the right middle fossa, there's as well as the posterior fossa, but there's a large, presumably contrast enhancing mass. We'd have to confirm by checking the non-con, but we'll assume it's a homogeneously contrast enhancing mass measured in the AP direction here, almost 4 centimeters, but it looks like it was extending. So if we pause there even, it'd have to go back, but into the cavernous sinus. I think I even noticed some fluid in the sphenoid sinus. An extensive component in the middle fossa. It looks like there's enhancement even going down through what might be ovale into the sort of infratemporal fossa there. Yeah, exactly. There's the entire dura on that side is a little thickened. Whether there's a definitive dural tail, I think I would probably consider it to have a dural tail. Yeah, exactly. I don't know if you can see my mouse or not, but yep, that's exactly the region I was referring to. But I think now with the corresponding coronal and sagittal cuts of this MRI brain and orbit, you see this homogeneously enhancing dural-based mass kind of in the spheno-cavernous region, extending through the skull base into the infratemporal fossa, most consistent with, a meningioma, and certainly explains the symptoms that we were seeing with the affluent pupillary defect, the ptosis. We'd have to go down and check the CP angle and the posterior fossa a little more thoroughly but I would imagine the tinnitus and the ear fullness are related to 7 and 8 involvement in this as well.
Well, actually, the tumor does not go that low.
Yeah, okay. Actually, yeah, no, you're right. The CP angle looked clean, so a little bit unusual to have tinnitus, but certainly the headaches, the cranial nerve 3 findings.
And what about her facial pain?
Yeah, in the cavernous sinus, I think you said it was the V2 distribution, but absolutely. I'm kind of surprised given all this tumor that we see going through what I think is ovale. She doesn't have V3 pain too, but it definitely is almost certainly related to this mass.
Okay. Anything else on your differential in addition to meningioma?
Yeah, so dural-based lesions. I can't remember the exact age of this patient, but I would always put a metastasis on the differential. It's unlikely given this is a solitary lesion, but couldn't rule it out. You can have slightly more aggressive sort of hemangiopericytoma or solitary fibrous tumors that can mimic meningiomas. And although this meningioma along the skull base, and we don't have a tissue diagnosis yet, but I would put grade 1, grade 2, or grade 3 meningioma sort of on my differential. It could be a more aggressive sort of meningioma variant, and we wouldn't know that without tissue diagnosis. As far as additional workup, I think a CTA would certainly be useful. I'd like to see the carotid and the degree of encasement or stenosis that this mass is causing. And then, yeah, I think I'll stop there.
Yeah, so she did have a CTA. Unfortunately, we don't have it here, but there is encasement and compression of the carotid in the cavernous sinus. Additional workup, she was seen by multiple subspecialties, plastics, otology, and also underwent endocrinological workup. So she did have progression of her facial pain and headaches, which were and worsening of the right ptosis. So she ended up getting admitted to the hospital for pain management, but there have been no imaging changes. So at this point, here's a summary of the case. So what are your anatomical and therapeutic considerations at this point?
Yeah, I appreciate the age being back on the slide. So she's only 34, which I think is really critical when we design our therapeutic plan. One question I'd like to ask her is sort of which is her most bothersome symptom or her chief complaint, because I think the likelihood of us being able to do an aggressive surgical intervention without causing significant and likely permanent neurological morbidity is quite low. But I think we could definitely achieve a couple of the goals of surgery, which would be to diagnose this and hopefully relieve some of her symptoms, potentially the most bothersome.
Sure.
But my anatomic consideration is, cavernous sinus invasion is sort of a major factor, given that most of her cranial nerves are not, that are in the cavernous sinus, they're not out, or they're, it sounded like her extraocular movements were initially intact. She has double vision now, so it's possible she's having some ophthalmoplegia, but we're going to make those worse if we do an aggressive resection in the cavernous sinus.
Sure. So Jake, you mentioned you want to know what bothers her the most. She's got admitted to the hospital for pain and headaches.
Right.
But what, on the exam and on the clinical finding, what are you concerned the most about in terms of symptomatic relief or preservation of function?
Yeah. So I'm most concerned about the vision loss and her visual symptoms. I think given her age, that's going to be a major detriment to her quality of life. But the pain is probably a close second. You know, she's admitted, you know, occasionally we've had to do, you know, urgent, you know, operations for trigeminal neuralgia. And this is not quite the same pathology, but you could consider it in the same sort of.
So what can you do for her trigeminal neuralgia?
Yeah, so actually something that I think would be a little bit out of the box, but you could do, you know, almost like a radiofrequency ablation through foramen ovale, although I want to make sure that she doesn't have V1 involvement in her symptoms, but you could do a biopsy, like a percutaneous biopsy at the same time as doing an ablation, although there's a big mass that might make it tough to get there. So that would be a challenge.
Okay. Well, what other options do you have? Medical, right? You can start with just aggressive medical therapy for her facial pain. So if your main concern is her blindness, so how would you put this case together in terms of your management strategy? You mentioned the cavernous sinus. You mentioned there's risk for permanent neurological injury with your surgery. So what are you going to offer her then in terms of managing her symptoms and this lesion?
Yeah, so I think I would have obviously a detailed discussion with her about the risks, but my recommendation would be
wait. Do we have a surgical goal yet? We talked about the most concerning thing being the vision and maybe secondary the trigeminal neuralgia, but have we established a goal of treatment?
No. So I think my goal would be threefold. Well, and I guess firstly we could try, you know, medical management. You know, things like Tegretol to see if the trigeminal neuralgia resolves prior to surgical intervention. But I think first is probably a tissue diagnosis, both to characterize, you know, grade and pathology, and then second to, I mean, if it sounds like she's not quite blind yet, but she's having worsening vision and blurriness of the right eye. So decompression of the optic nerve would probably be the second, would be my first goal after tissue diagnosis.
Yeah,
so you got tissue diagnosis.
Dr. Wong and I both come from the Van Loveren School of Skull-Base Surgery, and we are made to put the goals on the whiteboard in the ORs because, you know, when things go sideways, it's the goals that guide you, you know, whether you should do more, do less, and whatnot. So I think goals are always important to identify before you start going down the options. So you identify, okay, so tissue diagnosis, optic decompression, perhaps fifth nerve decompression. Then I think that takes us to the therapeutic options, right? To all the approach options and whatnot. So
absolutely, yeah. And I agree with you. I think if her trigeminal pain doesn't improve with Tegretol and or other, you know, atypical pain medications, I would add fifth nerve decompression at the skull base of the middle fossa. So I think in my conversation with her, I would recommend a middle fossa craniotomy. And I think you'd probably, in order to achieve an optic decompression, you're probably going to have to do a clinoidectomy. And I'm a little worried about the mass effect. Thankfully, this is on the right side of the temporal lobe, but even just retraction along the temporal lobe. So I think you may even want to do some sort of either like a full FTOZ or just a orbitotomy as well to kind of give you as much working space as possible with minimizing retraction on the temporal lobe. So that would be my surgical approach.
Okay. So your surgical approach is a right temporal or right FTOZ with orbitotomy and clinoidectomy?
Yeah, I guess, and I should clarify, depending on what she's 34. you know, that you could, if you have a good, although I don't think I personally would recommend this, but if you have a really good sort of ocular plastics team, and your goal is and her trigeminal pain improves and you're solely worried about diagnosis and optic nerve decompression, you could consider doing like a eyebrow type procedure, but it'd be much smaller. And I think the risk is higher of not achieving our goals with that operation.
Right. So well, let's go back to, so we identify, let's try to wrap this up. So we identify the goals as establishing diagnosis, optic decompression, pain relief. Do you think she wants to know about her hearing? Do you think you can offer her something for hearing from a neurosurgical perspective?
I don't. I'm still not completely sure where the hearing involvement or if this is at all related to the hearing loss. So I think, unfortunately, I would not be able to address
so Jake,
that.
I think the answer is on the screen here. If you think about her hearing loss, we had said it doesn't involve the 7/8 cranial nerve, but it involves other structures that are gonna affect her hearing. So what do you think?
I mean, yeah, I guess what you might be getting at is that the hyperostosis is changing sort of the conductive hearing ability.
Right.
And even if that's true, I still don't think I'm going to be able to drastically improve that with a surgical intervention.
Yeah, so there's, you know, the tumor is right on the middle fossa floor. So there could be extension of the tumor in through the tegment into the middle ear space. And that's also could be related to her chronic otitis media as it blocks off the eustachian tube. So that's not something you can do surgically from above to fix. And then what about, she's concerned, she's 34 years old, she's concerned about the way she looks with her right eye proptosis. Is that something you can help her with?
I suspect that's from occlusion of this cavernous sinus and plus potentially the hyperostosis. And so you could cosmetically address the hyperostosis, you know, with your craniotomy and your skull-based reconstruction. And that might help, but it might not completely resolve the exophthalmos. Okay.
All right. Yeah. So yeah, this is a very complicated case with a lot of different pieces given the size of the tumor and the different compartments it extends to. So as Dr. Jean said, you know, identifying the goals clearly, and then using your surgical options and other treatment modality options, such as, you know, a medical treatment and radiation, to design a more comprehensive treatment option for her. You know, that I think it's a very challenging case, and let's move forward.
Well, let me chime in a little bit. I think this is a great case to illustrate the process that I like to use, especially for younger trainees. The establishment of the goal, and then you say, okay, the major to do really here is vision, right? And really to do all the work for the vision, for the visual apparatus, really the corridor that you want, that is the anterolateral corridor. It gives you most freedom to getting there. So once you establish a corridor, then you can say, okay, what is my main opening into that corridor? And find the OZ or the you know, the terional plus minus is the way to always get to the anterolateral corridor. Then you can add on your modifiers. You want to take the orbit, you want to take the zygoma, you want to take the anterior clinoid. Those are the modifiers. So, you know, shameless plug, you know, because this is the subject that I talk about most in my book, is you start, you know, what your goals are, then you think about corridors, what are the openings to corridors, and then you modify it. And you did a fine job doing that. Once you identified the goals, you went down that route and you identified finally what the choice of approach is. So excellent work. Mike, your final thoughts before we go to Brad.
Yeah, I think it's as Dr. Jean said, you know, both of us train with Van Leeuwen, and we always like to talk about building blocks. So you establish your goal, and then you use the different pieces of your surgical options to build an appropriate approach. So yeah, so let's go on and turn this over to Brad and see how he approached this and what his thoughts were.
Yeah, absolutely. Yeah, I think that was just a great summary. And Jake, I think you hit on a lot of the considerations. I think, as tumor and skull-based surgeons, I think a lot of us, oftentimes go to the oncologic control. The presumption is this is likely a histologically benign tumor, but clearly compromising neurologic function. She's young and she has extensive disease. So theoretically, if you felt there were a safe and effective means of gross total tumor resection, I think that would be the goal, as is for many meningioma. I think in this case, I'm in agreement with you. This did not top my list of objectives and goals. I just felt that given the extensiveness of the lesion, there's probably not going to be a scenario where I felt safe to completely remove this tumor. And so that kind of made its way lower down on the list. Agreed that ophthalmologic considerations were kind of primary. She has a mild to moderate optic neuropathy and some progressive extraocular movement disturbance. Agree. I think a lot of it's from the hyperostotic bone, I think, which should be readily addressed. The component in the cavernous sinus, probably less so, but I think the majority of the cranial neuropathy is probably, or extraocular movement issues, were from hyperostosis. The otologic considerations maybe take kind of play second fiddle here, but could also be addressed and probably might be contributing to her headache in addition to the hearing loss. The trigeminal neuralgia being probably the most debilitating symptom. I think if you said you could address that, and she probably wouldn't care about the vision and the other things, kind of, at least in that moment. And I think that's the most challenging. And I think that's the one that we debated the most on. I think, just like Dr. Jean said, with a goal, taking the anterolateral corridor to decompress the orbit, get a bulk of the tumor, get diagnosis, and get decompression of the orbit and optic nerve. But do we do a larger operation to also decompress the fifth cranial nerve? And I think after we looked over this case and we spoke about it at our multidisciplinary tumor boards, the sense was, given the extensive infratemporal fossa component of this and how it really was intertwined with the nerve along its essentially entire course, from its kind of root entry zone to the face, felt that a more radical decompression was probably not going to relieve her trigeminal neuralgia, and we're going to rely largely on medical therapy. And then the cosmesis, again, young woman, addressing the proptosis and the long-term cosmesis of this. So that's kind of how we pieced it together, thinking about the objectives and kind of putting those in rank order and choosing a very similar approach to what you had suggested. So again, this is just further elaborating on that. We're going to have our otologist just help out and put a T-tube in while she was in the OR to address this chronic otitis media, optic nerve and optic and orbital decompression, aggressive medical management of the trigeminal neuralgia, and then addressing the cosmesis with orbital decompression. So just like you said, really a right pterional craniotomy with resection of the orbit, orbital hyperostosis, extradural clinoidectomy. Just thinking about other options, some people are more comfortable doing an intradural clinoid is always an option. Whether to tackle the intradural portion of this tumor at all, the portion that's within the temporal lobe, and then surgical modifications based on how aggressive you want to be and whether or not you want to tackle the component in the posterior fossa, maybe through a petrosectomy, going into the infratemporal fossa, taking more of the bone of the middle cranial fossa, really, again, with the goal to decompress the skull-based foramina and the fifth cranial nerve, and then also whether or not to approach the disease within the cavernous sinus. And I think all of these, once you've made this decision to do the initial portion, are all modifications that could be added, all based on your goals, kind of along the way that Dr. Jean and Dr. Wang are talking. You think your goals, and then that helps drive everything you think. And the other option that we always discuss, is standalone radiation. Again, my sense is, and the sense of our group was, this is a young woman who's going to require additional treatment above and beyond our subtotal resection. And so is there value in doing the resection? Is there an added benefit that warrants the risks of an operation above and beyond just doing radiation alone? So again, I think something to consider in specific circumstances. I don't think this being one, but something to consider. Also, the tossed around briefly the talk of radiosurgical management of her trigeminal neuralgia, were that to persist despite medical therapy, almost just above and beyond radiation for the actual tumor itself, but for treatment of the trigeminal symptoms. And so, pretty straightforward in terms of positioning and how we approach this. Supine, had her head, in Mayfield fixation, about 20 degrees head turn to the contralateral side, and just a curvilinear frontotemporal incision. Did a subfascial temporalis dissection to give us the exposure of the orbit. Did not take the orbital rim, although obviously you could do that. You could take down the zygoma, again, all depending on your degree of comfort with those approaches, how much you think it's going to add, and what your goals are. But we didn't do any of those modifications. This is really just a pterional craniotomy with a subfascial dissection, just to get a better view of the lateral wall of the orbit. These are just a couple snapshots here, I think, in this video, just showing the incision planning. Again, standard curvilinear frontotemporal incision. This is after the subfascial dissection. And then again, this is kind of with the muscle mobilized kind of inferiorly and largely posteriorly to kind of provide our window and our corridor to start our bony work. And then generally the way I'll do these is, proceed with a craniotomy, a limited craniotomy, just as like essentially a big burr hole almost. And then a lot of this is get a giant burr in there, and start big, and then sequentially go down. You can see here kind of in the foreground that the orbit itself has been widely decompressed. We're now working back towards the orbital apex with, progressively smaller diamond burrs with constant irrigation. This is probing into the optic foramen. We try to decompress the optic foramen extradurally before we tackle the clinoid. This is just periodic stealth navigation, helping to delineate the extent of the clinoid. This is now working on the optic strut. You can see the optic nerve is decompressed and the majority of the clinoid's out, and this is kind of flicking off that last piece of the anterior clinoid process. This is after kind of complete extradural dissection. You see what I'm doing now is probing along the orbit. You see the entire orbit free. That's the lateral rectus muscle there. And so you see the entire superior lateral wall of the orbit has been completely decompressed. The entire optic nerve in the foramen has been decompressed extradurally, and the clinoid's out. And that gets us our kind of bony exposure and optic decompression, and really accomplishes the majority of the goals that I think we set out for. Again, you're still at this point where you have yet to see tumor aside from the hyperostotic bone. And so we did want to, both for getting a histologic diagnosis and to get some of the bulk tumor that was starting to cause some compression of the temporal lobe itself, opened intradurally. You see the optic nerve intradurally. You see kind of this bulk of tumor that we go in and try to remove this. This is working the optical carotid cistern. And again, just teasing some additional bits of this tumor out, then ultimately opening up the falciform ligament and the proximal portion of the periorbita overlying the optic nerve, just to again ensure that the nerve itself is completely free along its entire course and not compressed by tumor. We then ultimately, that showed here, removed kind of this very affected portion of dura prior to proceeding with the final repair. And you're proceeded with standard kind of dural reconstruction with Duragen. And then, for these, we like to work with our facial plastics colleagues and oculoplastics colleagues, but the lion's share of the work's done by our facial plastic colleagues. Oftentimes we'll do a titanium mesh cranioplasty. Obviously, a variety of options here. Some people will pre-make a peak cranioplasty. You could use cement, but we find that the titanium mesh works very nicely. Whether or not to do orbital reconstruction, we tend to reconstruct a portion of the orbital wall. People worry about pulsatile and ophthalmos, but especially with a very large decompression. So we reconstruct the anterior portion of it, and then resuspending the muscle. We use these juggernauts, these kind of cool little basically screws that screw into the bone that have suture attached to them. Helps resuspend it to get nice cosmesis, and then standard closure. So, not surprisingly, immediate kind of moderate worsening of her baseline optic neuropathy and third nerve palsy, presumptively from manipulation. But I think, always a concern is just heat from the drill, over manipulation. And so those are things that we're obviously very cognizant of during the operation. You can see the immediate post-operative CT. You can see both the orbital reconstruction and the reconstruction of lateral orbital, and the bone of the convexity, kind of recreating nice contour there, and see some of the muscle edema and under the flap. And I actually saw her just a week or so ago. And so improvement of optic neuropathy, basically back to baseline. So it has pretty good vision in that eye. Near normal eye movement, very, very imperceptible, subtle kind of dysfunction of her lid, but basically normal. Has improved hearing on the right side. Has moderate to severe sensory neural hearing loss, but really good word recognition on audiogram. It's going to be getting fitted for hearing aids, and really dramatically improved pain control. That is with working with our pain management folks, and it's been it had been a kind of a slug, kind of getting that under control, and she's now starting to kind of wean off things and is on a reasonably stable kind of regimen for her pain control. And so I think in terms of reviewing clinical outcomes, in terms of oncologic control, we'll see on an MRI, but expected residual disease. We weren't planning on tackling either the posterior fossa component, the component along the fifth cranial nerve, or the component within the cavernous sinus. The plan is going to be for discussion regarding external beam radiotherapy. I just think given her young age and the extensiveness of this lesion, it is unlikely that she will not require additional treatment. And the question is really just regarding the timing. Do you watch and wait until she progresses? Do you do it up front? And if so, what kind of radiation? Is this a case where you consider protons? From an ophthalmologic standpoint, she's basically improved back to, or if not better than baseline. And again, I think we were playing for the long term here in terms of her vision. So I think we've accomplished what we wanted to in terms of preventing future vision dysfunction. Hearing's improved, and overall seems to be doing well in that regard, with improved pain control as regard to trigeminal neuralgia. That's obviously not from the operation, is really just from time and medical therapy. And then from a cosmetic standpoint, has healed really beautifully. Proptosis has improved. And so she's satisfied from a cosmesis perspective. Here's our post-op follow-up. You'll see, and we'll have a comparison on the next image. Obviously, the component in the cavernous sinus and the skull base is still there. We've removed the entire temporal component, all of the hyperostotic bone of the lateral orbit and the lateral portion of the temporal bone. And so I think, decompress the temporal lobe and decompress the orbit, kind of accomplished our goals, but are still left to tackle this residual disease.
Great, thank you very much for that the summary. Yeah, so again, a very challenging case.
So I'm chomping at the bits to get in here. I didn't get to moderate this one, and I'm just, this is a great case, Brad. Thank you for bringing it, because I think it's all too often, as on this webinar as well as other places, where the surgical goal is just so nonchalantly put out as total resection, always total resection. Why do we talk about anything else? And on this webinar as well. And this brings up the point that total resection may or may not be the right decision for all cases. Well, certainly not the right decision for all cases, but in many cases, it's maybe not the right thing to do at all. Having said that, I've recently hung out with a lot of surgeons who would have done something different here. So I think we all know people who would advocate the following. Well, you should maybe do a BTO, take a look at that carotid and see how narrow it is. and considered doing a bypass and not go into the cavernous sinus per se, decompress the cavernous sinus fully, maybe go into it, but addressing the fifth nerve a little bit more. It's not tackling the fifth nerve that maybe is the most controversial. Like, why not do, even if the BTO says that she passes and she doesn't need a bypass and whatnot, why not go infratemporal fossa? Why not, maybe numbness, after all, is better than pain. If you have to cut the third division of the trigeminal or whatever division that's involved in the tumor, maybe trading numbness for the pain is better than suffering the pain. Now, it's hard to argue with success because obviously she's getting better. But I have no idea what Dr. Nanda is going to say and which side of the fence he falls on this topic, which is why we have a referee for all these sort of things. Michael, what are your thoughts about this? Is a more radical goal reasonable or unreasonable?
I think in my thinking, with regards to, I think the more radical goal is, in my mind, less reasonable. I think with the fifth nerve decompression, I think you're almost certainly going to be causing some degree of numbness in the face, and I think unless she has demonstrated that she's failed medical therapy completely, or she can't tolerate the medical therapy, I think numbness is not necessarily a better trade-off than pain. And numbness can actually be more functionally limiting than pain at times if they can't eat from that side of the face. And then in terms of the BTO and the carotid, I think I would have considered doing an angiogram to look at the flow, because one concern that I might have had is whether or not the intermittent blurry eye blurriness or blindness in that eye could be a result of ischemia rather than just compression to the optic nerve. But I'm assuming on the MRI that she doesn't have any DWI changes or any other signs of ischemia, but that may be a consideration for bypass, not so much in terms of preparation for going into the cavernous or tumor resection, but just flow augmentation due to the compression of the carotid.
Yeah, and I think that's a really good point. Again, I think at the time, I don't think we felt that she had symptoms of ischemia related to what is significant carotid stenosis within the cavernous sinus from this lesion. And again, because our intent was to not tackle that disease within the cavernous sinus, we weren't going to plan to go with the BTO. I think the thing we debated most was the fifth cranial nerve decompression. I think ultimately just felt that, just as Mike said, I think even if we were to do a bony decompression of this and remove some of the tumor, we either trading off the numbness for the pain or the likelihood that it's not going to make a huge impact. And there's still going to be residual disease left that's going to require some kind of thought process, which is why we ultimately didn't tackle that. And her pain was able to be controlled even preoperatively with medication. And we kind of always leave that option. But yeah, that's why I find this case interesting and love to hear from seasoned kind of skull-based surgeons, what they would do. Because again, you do hear people throw things around like that. Very easy to say, you bypass, take out the cavernous sinus, take out this, but I think when you're looking at a patient and you're kind of considering your goals, it's important to take the risks of all those additional maneuvers into consideration.
Well, it doesn't get more seasoned than Dr. Anil Nanda. So let's stop our screen share here and let him share his screen. And let Dr. Nanda give us the truth.
So I have had the truth serum, so I will tell you that. How many minutes do I have? Is it only 13 minutes?
No, as long as you have wisdom to draw, please. We go on to.
So first, I want to congratulate Michael for doing a great job with masterfully doing this with the Golden Gate in the background, and Walter with that doesn't look like the Sistine Chapel, but the opera gives it the ambiance that The only thing missing was a bottle of wine. So I think this was very well done. Jake, you were superb. You handled everything really well. If I was your board examiner, you just passed. Not only that, I'd give you a score of 4. So thumbs up. And Brad, you're a master. I mean, I think, you know, the one thing that before I say, you know, I love the goals and stuff, but in surgery, for some people, it's a rational art. Like those who split and those who lump. I'm an intuitive surgeon, okay? So if it's soft, I'll get aggressive. If it's hard, I'll get out. You know, so I think the lay of the land depends a lot, and the best of plans will fall apart with a tumor that's implacable. The first thing I would say at the onset is this tumor is unresectable. You cannot get a total resection. You can do bilateral carotid bypasses, it ain't gonna happen, okay? This is not somebody you can cure. We know the Simpson grading is gonna have a recurrence. It's a young person. So I agree with everything you did, Brad. And I think the bravado of skull base always has to be tempered with the realism of, you know, if this was my sister, what would I do? And that's something you never forget, because you can say, I mean, and we see this, we see people with beautiful post-op MRIs, but you don't know what the status is, you know? So, I mean, I had a few slides here. If I can share my screen, I'll try doing that. So I had some, here it is. Can you see my screen? Is it still on?
Yeah, we're good.
But it's not on slide. It's, okay, good. So you know, the topic, why the owl of Minerva flies at dusk. You know, in the Roman history, Athena was the symbol of wisdom and the owl was her symbol. And the whole thing about the owl of Minerva flies at dusk is a tribute to people with gray hair, that when you get wisdom, it tempers your judgment. And you're like, you know, maybe this is not a good thing to do. You know, we've all had petroclival meningiomas that have, you know, humbled us incredibly. And some of the simplest things can have big complications. So that's why I thought this would be a good topic to say. Now, quickly, this is an en plaque meningioma. We know these are about 20%. And I think the main thing is recurrence rate is very high, because you're not going to get a good resection, obviously differential diagnosis. Jake, you got a 4 from the ABNS for doing that well. So I was proud of you. I'm going to call Eddie Chang and Mitch Berger and tell them they've got a superstar growing out there. And, you know, I think cavernous sinus extension, locally invasive, most are great. So I think most of you, this is repetitive, tumor burden decrease, optic nerve, decompression, and things like that. And I think radiation, I prefer early radiosurgery, though I think the target here may be too big for radiosurgery. So I think I'm going to quote that paper later. I thought I'll show you some of my cases en plaque. You can see this. In the interest of time, I'll skip the video. The only thing, Brad, I would have done differently in your case, I might have split the fissure. But that's a personal bias. I'll split the fissure if somebody has malaria. If they've got like lumbar stenosis, I'll split the fissure, because I love splitting the fissure. But I think part of opening the fissure is you do get, might have seen something a little more deep or better. I would have done it. You did a beautiful dissection. You can't argue with the success and the outcome of your patient. You know, a functioning person with better results. And I can tell you in experienced hands of people being more aggressive, this could have had a very different outcome. So I think, you know, as they would say, we are not worthy. Excellent, excellent result. I think we're all proud of you in that. I'm going to skip these videos. I had some videos on this. You know, just splitting the fissure. Another one like that en plaque, because it's somewhat similar to the case I showed you here. This, I love, you know, I use the CT stealth on these cases because I just go, it's very accurate with the CT stealth. And then I just drill off the entire thing. I like the way you guys reconstructed that, Brad. That was very, very cosmetically nice. So kudos to your oral maxillofacial. I'm going to skip these videos just in the interest of time.
Actually, Anil, don't feel like you need to rush. You know, the audience will stay with you as long, and plus we record.
Let me show you one. You know.
So yeah.
So just the devascularization, going out for, you know, meningioma. You know, and I love when you guys say, "What are the goals? What are you going to do?" You know, it's like preparing for battle. The battle scene changes, and then you have to be resilient, and then you have to say, okay, you know. And I tell residents that there are times when you can accelerate, and there are times when you have to decelerate. And the great surgeons are the ones that know when to decelerate and when to accelerate. And I think that plan you can't decide. You cannot say, okay, this is what I'm going to do. It's not painting by numbers. And I feel complex surgery is gestalt. You know what I mean? It's not like a repetitive ACD, boom, boom, boom. I think here the foe is much more formidable. So here you can see we've split, we've gone down, and we're peeling this part out really well. Again, it's like staying in that arachnoid plane. You know, you can get that. And I think these are basic. This is an MCA was very adherent to this, so I had to peel the MCA off. In this patient, you can see we handle that well. Another one here with a lot of bony thing. But again, you can see the proptosis. I drilled all this off completely, and I'll skip this. Yeah. So I just, you know, I think the anatomy is important. I think for all the residents watching and thinking, anatomy is still king, okay? You cannot argue with anatomy. If you don't know your anatomy going in here, you're gonna get lost and you're gonna get into trouble. This is just from the Roton Atlas showing you all the nerves, V1, V2, V3, how we get there, the carotid. Now I can tell you when I trained at Pittsburgh, I mean, we drilled the petrous apex off, we did a bypass from the carotid to the supraclinoid carotid. It was like an acrobatic act. You know, you just weren't eating like this, you were eating like this, and you were going this way, and you were on one foot in the complex yoga position trying to do this. And, you know, I mean, as much as we want to say it's a technical feat and it does great, the results, there's a complication rate with bypass, right? It ain't, you know, it's not your routine carpal tunnel syndrome that everybody's going to go home, you know? So you want to balance that always. And again, anatomy is something we like. And here's somebody with a cavernous sinus meningioma that is rare, where I took this out completely. Why? Because it was soft, you know? I mean, the whole thing came off, and it's like Miller time. Like, oh my God, I'm so good. I'm like, you know, I'm glowing how good I am. Well, and then you get humbled, you know what I mean? So in this case, this is a complete resection, but you get cases like this, and you can see these are large tumors. You know, you're not going to get a good resection. So here's somebody, I mean, I think you can do a double bypass on this one, and you can clear out both cavernous sinuses and give this patient complete ophthalmoplegia bilateral. You're still not going to cure the patient. And I think the realization that there's some patients you're not going to be able to cure is a very important starting point. And I think that bravado that we sometimes have, I can do this. I'm God's gift to skull-base surgery. I have no complications, and all my patients go home on post-op day 2. I mean, I remember going for talks like that. When I was a young attending, I went for a talk on an acoustic and said, well, all my patients go home on post-op day 2. I'm like, hell, my 5-centimeter acoustics are still in the ICU on post-op day 3. You know what I mean? So I think that realism is very important. You know, I've done about now close to 700 skull-base meningiomas, and I've been deeply humbled. But again, I think the anatomy is important. This was our series on cavernous sinus meningiomas. Now I think we're close to almost 100. And, you know, internal carotid artery encasement, limited resection. And the important thing, our paper I felt found, this was the same with the Karolinska group, that if you did early radiosurgery, your recurrence rate was much lower. And I think that's an important thing. That's why I favor that. This shows you how the function between the two recurrences when you do early radiosurgery. I'm a big believer in that. And, but you know, this is even my petroclival meningioma. You know, I have total resection rate of only 28%. I'm not going to tell you 90%. But I do think my results are, you know, my outcomes are bad. Okay, so you can have beautiful post-op MRIs, but if you don't have outcomes there, how would the patient do? So this is sort of our thought process. And I think this was from Michael's institution that I think changed the paradigm on cavernous sinus. This is Charlie Wilson's paper with Larson. And I said their progression-free survival rate, 77%. And I think that tells us that Brad's patient will do well. Just to show you the growth rates on these, that these tumors do grow. And, you know, again, I defer from Michael McDermott. They said, you know, their whole theory was that you're not going to make a difference on Simpson grading. And I'm a big believer in Simpson grading. I think in our study with all our meningiomas, even with skull base, it showed a big difference. We published that in JNS. And I mean, you look at recurrence in, with aggressive surgery for cavernous sinus meningioma. I mean, it does. If you do a partial resection, your progression rate is as intuitively expected better. And even with radiosurgery, so I mean, I tease Dr. Lunsford that, you do gamma knife and all this stuff, there's still progression. It's not like everybody gets controlled. In our own series, we just did a small series when I was in Louisiana. I mean, we had a recurrence rate of 43%, which you could argue is a blistering failure. So I think you need to recur. These are just some SRS series. You look at the failure number of cases, and it's significant. It's not, it's almost between 7 to 10%. So I think it adds up. Yeah. So I want to say hello to everybody from Rutgers. We have a wonderful group of people, and we're going to have a global neurosurgery update educational summit in November 3rd and 4th. So I want all of you to come for that. And our focus is, how do you teach the next generation the skills to operate? So I have two of the best technicians in the world, at least in my opinion, Majid and Robert Spetzler, talking about how they train and what we need to do so that the art gets better, so that Jake is a better neurosurgeon than any of us on the panel. You know what I mean? Or that young generation improves. And I think that's almost something we need to be real careful about. So I started with the owl of Minerva, and I'll say it again, that the owl of Minerva spreads its wings only with the falling of the dusk. So Brad, when you're in your 60s, you're going to say, Anil was right. The owl of Minerva flies at dusk,
I feel it now, so.
That's because you're honest, Brad. I always tease the radiosurgeons that our life expectancy for open skull-based surgery is definitely less. Our myocardial impact is much more because, you're like, oh my God, what went wrong? You're like calling the ICU at 3 in the morning. Did the patient get better? So, and I wouldn't trade that for anything in the world. I mean, I still tell the resident, I can't believe they pay me to do this. I did a nice acoustic, I did a brainstem, filocytic astrocytoma this week, and those things, and that's what I want to tell Jake. Jake, this is what it's all about. The joy of neurosurgery, you kind of remind me of that movie Chinatown when they tell Jack Nicholson, take it easy, Jake, it's only Chinatown. So I think we can't talk, we were doing this virtual stuff, it's wonderful, and this is the rainbow that appeared at the height of the pandemic. And I knew things would get better with this, even though the Delta variant is coming. And it says, it's a serious thing to be alive on this fresh morning in this broken world. It's one of my favorite poets, Mary Oliver. So I'm open to, I'll stop sharing so we can talk some more on this.
If there are any questions from the audience, please put it in the chat or the Q&A. We will field all of them as we go. Thank you, Dr. Nanda, for that, the pearls of wisdom that you just gave there. And thank you tremendously for the best title that any of our webinars have ever had. I knew when you were going to be the discussant that I should ask you for the title, because you didn't disappoint. It certainly was the best title we've ever had, and of course, thank you for all that wisdom, Brad. The applause to you is that it's too easy for young surgeons to come and feel that they have to prove themselves with total resections and technical wizardry to be educational. What this session proves, and Dr. Nanda's comments especially, is that wisdom doesn't necessarily mean technical wizardry and showing off and all that. It means doing the right thing for the patient, which ultimately is the goal. You have to do the right thing for the benefit of the patient. That is, in fact, your job, not the technical wizardry that may or may not come with it. So thank you for that, because that's sorely lacking, in our field. Jay, great job. And Michael, thank you for moderating. There's no bias there with your own resident. I knew that was going to be the case. So anybody with any closing comments before we call it? So thank you for everybody for participating in this webinar. We actually don't have a scheduled one for September yet. There are cases that are cooking. This is a good place for me to say out there, any surgeons with any interesting cases with high teaching values, complexities, decision-making issues, please let us know and we will get you on. And we look forward to another great session in September. The case may come from my library. Who knows? We'll see. And then we'll might beg Anil for a title again. So let's see. We do have one. Let's see. Is that a comment or a question? Okay. Anyway. All right. With that, thank you everybody for your participation. I'm greatly indebted to you. Have a great evening. Thanks, and see you soon again on Surgeon's Log or in person.